Great. Okay, so I want to welcome everyone back to another session of Cardiology Grand Rounds here at Mass General Hospital. Before we get started with this week's session, I wanted to make a quick but important announcement about some upcoming sessions. So next week, we'll be having the first of our Harvard Medical School-wide cardiovascular Grand Rounds sessions, which is a session that will include participation from our division here at Mass General, as well as the cardiology divisions of the Beth Deaconess Medical Center and the Brigham and Women's Hospital. We plan to hold 3 of these HMS-wide cardiology grand rounds per academic year, and each session will be hosted or led by either us here at Mass General, the Brigham, or the BI, but each will include speakers from all 3 institutions. And so the first session next week will be hosted by the Brigham and led by Drs. Callum McRae and Mark Pfeffer, but again, we'll include speakers from all 3 institutions. We will plan to hold the next event likely in October that we here at Mass General will be hosting. Now, most importantly, each session will be held at the day and time of grand rounds for the hosting institution. So next week, we will be having this combined cardiology grand rounds at the normally scheduled day and time for Brigham cardiology grand rounds, which is on Monday. So Monday, May 3rd at 1 p.m. And also we will not have our own grand rounds next week. And the same is going to be true of the other institutions whenever we have this event. So I just want to make that quick announcement. I encourage you to check your inboxes likely later today or tomorrow for more information on these sessions and particular details on next week's session, but we're all very excited to have these collaborative opportunities. So for this week, it's a privilege now to be joined today by Dr. Andre Davila, who directs the Arrhythmia service at the BI. He has been invited here on behalf of our electrophysiology section, and hosting today's session will be Dr. Connor Barrett, who's the clinical director of our Arrhythmia service here at Mass General. So thanks, Dr. Davila, and Connor, I will turn it over to you.
Well, thank you very much. It really is a distinct pleasure and honor to introduce you all to my friend and colleague, Dr. Andre Davila. Andre is the section chief of the cardiac arrhythmia service at the cardiovascular medicine division at the Beth Israel Deaconess Medical Center. He's also an associate professor of medicine at Harvard Medical School. Dr. Davila graduated from medical school in Brazil in 1988 and completed his residency in cardiology and electrophysiology in Sao Paulo, Brazil, and indeed thereafter in Belgium and the Netherlands. He subsequently undertook 2 postdoctoral programs in cardiovascular research and experimental electrophysiology at Harvard Medical School and at Mass General Hospital, where he subsequently was on faculty here until 2008, when he left to further develop arrhythmia programs in New York and subsequently Brazil. Andre's research interests include ablation techniques for patients with atrial fibrillation and ventricular tachycardia. He's an internationally renowned teacher, clinician, and researcher. And towards that end, in 1996, Dr. Davila and his colleagues in Brazil pioneered the approach of epicardial access to facilitate ablation of epicardial circuits in patients who have epicardial ventricular tachycardia circuits, which is a particular problem in Brazil for patients with Chagas cardiomyopathy. As a result of his research interests and indeed his ongoing success, he has published over 200 articles and book chapters, as well as possessing a number of patents to his name. In his spare time, he is also the co-director of the very prestigious annual International Symposium on Ventricular Tachycardia. So it's my honor to introduce Andre Davila to you all. He's a true leader in the field of catheter ablation, and I know we're all looking forward to listening to him speak today. Thanks, Andre, and looking forward to hearing what you got to tell us and educate us on, as always.
Thank you very much, Connor, and all my friends at MGH. It's more than a pleasure. It's a real honor for me to have the chance to talk to you about the topic that it's been my passion since the very beginning of my EP career. So to show you that, my very first article, interesting enough, in Vt ablation was to show why Vt ablation fails. So I was a fellow in Belgium around that time, and I had some thoughts in terms of the reasons why we were not very successful in terms of Vt ablation when we had to deal with this difficult population. At that point in 1994, the reasons, there are several different reasons, we decided to concentrate in 4 of them, which is, one of them is because we were speculating that the scar, the infarcted area was just too large and would be able to sustain multiple VT morphologies. This is the beginning of our research in terms of leading to epicardial catheter ablation, and there was some data suggesting that in those patients with epicardial ablation, endocardial ablation would always fail. And also there was a problem, which is, we'll talk about this during this presentation, which is in some VTs, or not in most of them, we have some properties of the VT circuit that can only be identified during VT due to their functional properties. The approach to VT ablation has, since the early days when Mark Josephson had his pioneer work in patients with VT and was able to take them to the OR, there has been a huge change on the classic approach. Because of the nature of the circuit that was
Andre, this is Patrick. Sorry to interrupt. Your slides are, at least for me, only it's cut off, like the word approach and everything to the left there. I don't know if it's worth trying to go out of share screen and then back into it again. And Krishna or Connor or anybody else on the panel, do you see the same issue? Or
Yes, we were just picking that up now as well. Yeah.
It projects okay for me, Patrick. Do you see it now? Do you see it better now?
we don't see it yet, but let's see if it comes through.
You see it now?
You can see the full screen now, and now we see the,
What about
now? Now it's good. Looks great. Thanks.
Great.
Okay, thank you, Patrick. So as I was saying, over the last several years, there has been a very important change on the way we approach VT regarding ablation procedures. Initially, because of the nature of the problem, that the VT circuit was always related, and it still is related to the areas of scar, the approach would require several VT inductions so we could understand the mechanism and the properties of the circuit. And we were basically defining the substrate based on voltage. You know, the scar regions have lower voltage than normal tissue, and this was very useful. And once we knew the VT that we're able to induce and the kind of the size of the scar, we were able to use different EP maneuvers, which we're not going to talk about today, and define the area that was potentially helpful for ablation. To test if the ablation was useful or not, we would have to re-induce at the end of the procedure and hopefully make all VTs non-inducible at the end. Most recently, because several changes on the way we map, that we're able to map, the approach has changed completely. Now, instead of using VT induction, a lot of the procedure is done during activation map, done during normal sinus rhythm and pacing, which is extremely important for the patient since we don't need to induce all the time, which can sometimes make the clinical stability of the patient. We can compromise the patient's clinical stability. And most of the procedures that we're using now are voltage independent, as we are paying a lot more attention on the activation map itself. And more important than anything, we are now using a lot of imaging, pre-procedure imaging, to help us, to guide us during the post-procedure ablation. Let me talk to you what exactly happened. This is a busy slide, but I just want to emphasize that from the very beginning, even though we are dealing with the same VT problem, the way we see the problem now is completely different. It took many important contributions to the field for us to now be able to delineate the circuit, as I can show you here in this beautiful slide. This is much easier to understand and interact with rather than the intracavitary electrograms that we only had in the beginning of this evolution. Let me try to use a case create some examples that may be helpful for you to understand where we are going with this. This is it's a classic patient. The patient had a post-MI and came to the lab after several episodes of syncopal VT, despite of the use of amiodarone. So when we are there evaluating his LV function, we are able to see this immense anteroseptal aneurysm. So what are the options that we have to treat these patients? We can offer them an ICD, can go with antiarrhythmic drugs, radiofrequency ablation, surgery, all of the above but surgery, or for my patients, for many physicians who don't really care about this kind of clinical condition, they will always refer these patients to EPs, which is what we love to do. Let's try to understand some of these options one by one. The ICD, it's the most painful treatment for VT because it does not solve the problem. It's very effective in preventing sudden death. These patients have a high risk of sudden death, but the only thing that the ICD does is to stop that specific ventricular tachycardia. So when the patients have shocks, these shocks are typically very painful, and in one way, they can actually increase mortality rather than prevent mortality. So this is the reason for that is because multiple shocks can actually result in progressive heart failure. So it's important for the patient, but it's not helping him long term. Another option is to use the best antiarrhythmic drug that we have out there, which is amiodarone. And we know that in patients who never had amiodarone before, never took amiodarone before the first episode of VT, the results of amiodarone and ablation are kind of similar, at least until the patient presents the first recurrence. Because when the patients present a recurrence, these patients are already taking amiodarone, ablation is much better than to simply escalating antiarrhythmic drug therapy by increasing the dose of amiodarone or adding a second antiarrhythmic drug to the patient's treatment option. The problem with amiodarone, as you all know, are the multiple side effects that the drug presents that may actually prevent a physician from using this drug in the adequate dose for a long-term follow-up. The ideal approach for all the VTs would be the ones that we would be able to first control VT recurrence and at the same time improve LV ejection fraction and hopefully be able to treat some residual underlying heart disease. One potential option for the patient that I just presented to you would be surgery. There are different approaches, and this is the one that we have a good experience with, which is the left ventricular reconstruction, when the surgeons can fix the septal and the anterior wall by removing the anterior wall aneurysm and fixing the septal wall. When we do so, first of all, there is an important improvement of the LV ejection fraction. This is extremely important for the long-term outcome. And it's also important to note that depending on the approach that we use, your VT recurrence can be very low. So depending on the treatment that you're offering, specifically for one given substrate, your VT control can be very good. But this data, even though it's a node data, it's important because it shows you that if you follow the patients long enough, you will realize that despite of no VT, no ischemia, because the patients were treated here, and a much better LV ejection fraction after the surgical procedure, the mortality rate is still important. I'm not sure if we will ever be able to change mortality by simply ablating VT. But because VT remains a very important clinical problem, all the efforts that we can do, that we can offer to patients to control VT recurrence, I think are acceptable. It's also important to talk and to tell you that this data clearly shown in the past that depending on the substrate and the patient population that we are dealing with, we don't need to induce VT to obtain a reasonable treatment to control VT recurrence during the long-term follow-up. This is the procedure that we were using here. Basically, after mapping the VT prior to the surgical procedure, the patients were taken to the OR where no intraoperative mapping was being done. But again, because this is a specific substrate of patients, the results in terms of controlling VT recurrence were excellent, despite the lack of intraoperative mapping. We're going to use this during the presentation to tell you where we would like to go. This is one of our patients here from VI. I did this case a few weeks ago. It's a similar case to the one I just presented to you where we had this surgical solution. The problem with this patient, despite the VT storm, the patient had no signs of heart failure, had no thromboembolic complications. So it wouldn't be, surgery wouldn't be his very first option then. So the idea was basically deal with his main clinical issue by the time of his presentation, which was VT recurrence, VT storm. But what we had to do with a catheter, it's really difficult for clinicians to understand how can we possibly deliver an RF lesion, which will cause a small lesion that is not bigger than 4 millimeters. How can we possibly ablate such a huge scar without removing the scar and yet be able to control the VT recurrence? Let me show you very few EP tracings for you to understand why this is possible. This is a node case of us. As you can see here, it's a patient with an inferior mine, even calcification along the inferior wall, with a massive scar along the inferior wall. Despite of that, during VT induction, we were able to find one specific location that terminated and rendered this VT non-inducible after 2 seconds of application. How is that possible? In EP, we use some maneuvers and we analyze some local electrograms during sinus or during VT map. And we know that some of these abnormal electrograms, depending on the pacing maneuvers that we use, we are able to demonstrate that this electrogram seen in sinus can actually be the substrate for VT. When we find this kind of electrograms there and we ablate, we are able to finish VT during a very short application. The reason for that is presented here. This is a slide that was given to me by my mentor, Dr. Jacques de Bakker in the Netherlands. And this slide summarizes a lot of the concepts that we needed to understand in EP for us to ablate VT. He took a slice after surgery of the infarcted region. And what you see here in white is scar, and in black here is surviving muscles transversing through the scar from one side of the scar to another side of the scar. As you can see here, there is a tract of survival bundle that stops at this level. It stops here, but it will connect with another channel of survival bundle a little bit higher. And this one will then connect to the other side of scar in a little bit higher level. What you can see here is the representation of the tract that we have to ablate. This is the substrate for VT, which is of course a 3D, has a 3D course in many of our patients. Now it's easy to understand that instead of removing the whole scar, which is what surgeons can do in the OR, we are able to ablate VT if we could find this little tracts of survival bundle. If I ablate here, the whole scar would become non-inducible. It would not be able to sustain VT. That's why catheter ablation, since we know the substrate now, we know the substrate better, we can actually, without removing the scar, making it non-inducible, as Most of the scars are after post-MI, for instance. As you know, a minority of patients with post-MI cardiomyopathy will develop VT because there is a need for a special arrangement of the survival bundles inside the scar for them to be able to sustain VT. If we can find and eliminate these small tracts, we can actually make the whole scar non-inducible, even though we are not removing the scar from inside the heart. More recent work from the University of Chicago clearly shows that these tracts can be located endocardially, epicardially, but in the vast majority of the patients, they will have a 3D configuration. If they have a 3D configuration, we may have to ablate them, part of it endocardially, another part epicardially. Depending on where we go, on where we find, we should be able to abolish a circuit with an epicardial or an endocardial ablation, or sometimes using both approaches. What is epicardial ablation? So epicardial ablation is a way for us to enter the epicardial sac, the epicardial space, dry epicardial space, so there is no effusion here, and we use a 2E needle to assess the pericardial space. And by doing so, we can maneuver our mapping catheters around the epicardial surface of the heart and use more or less the same EP criteria that we use to define important endocardial sites for ablation. We can apply those principles to the epicardial surface of the heart. This technique was described several years ago. We got a book published 25 years, the initial description, and it's basically summarized here. So we can, using the same criteria, define areas of interest that should be ablated along the epicardial surface of the heart. This is important because until 1996, this wasn't done. The only way for us to approach possible epicardial circuits was during surgery in the OR. Let me show you a nice example. This is a basketball player that we saw a few years ago in Brazil. This patient had this QRS here with a positive signal average and had this easily inducible VT. He came to the hospital because of syncope. What's interesting in this particular situation here is that the endocardial electrograms that you can see here are completely normal, but the epicardial electrograms were very sick, were very abnormal. So this is an example where the patient had an epicardial only circuit, was not endo, was not intramural, was totally confined to the epicardial surface of the heart. And since we're able to map there, VT was rendered non-inducible about after this application. This is another interesting case. The patient came to the left in incessant VT, waiting for a heart transplant, which happened 10 days after this ablation. And we went to the epicardial surface of the heart, able to identify the circuit and ablate there. And as you can see here, the layer of scar, which you can see in this region here, it's totally confined to the epicardial surface of the heart. It doesn't make any sense for us to ablate endocardially to go all the way through the wall, which is extremely hard to do. And we would have to use very high energy here and perhaps have more complications if we can instead map the epicardial surface of the heart and ablate there. Most patients in whom the epicardial circuit predominates are patients with ARVC, then Chagas, that was the reason for the technique to be developed in Brazil, and so on. But even in patients with post-MI, from time to time, and I'll show you an example of that, we have to enter the epicardial surface of the heart. One of the main problems that we have when we're dealing with VT is that 70% of all inducible VTs are unmappable. And they are unmappable because they cause hemodynamic instability during the case. The blood pressure will drop significantly, and we have to stop the VT. And we don't have enough time to map VT as we would like to do. Because of that, in 2010, 2011, we decided to change our approach and to offer hemodynamic support for all our VT cases. Hemodynamic support is fantastic because, as expected, if we have the patient with an impeller device, we are able to map his VT for a much, much longer period of time. And by doing so, we were able to stop many of these VTs. The problem is that even with impeller, every single time we had to induce an episode of VT, this will cause a cumulative deleterious consequence for the hemodynamic condition of the patient. As you can see here, this is cerebral oximetry, which starts in a very good level in the beginning of the procedure. Every single time we induce, and inductions are represented here by this sudden abrupt change in the cerebral oximetry, the patient never gets back to his baseline condition. It's a cumulative problem that at some point will cause us to stop the procedure. In this particular case here, it was after 6 hours of multiple induction attempts. And we know why that happens. This is data from patients who had an ICD implanted, and the lower the ejection fraction, the longer the time for the ventricular function to recover. So most of the patients that we ablate have a low ejection fraction. And as we keep inducing, it takes much longer for them to recover. At some point, we have to stop the procedure. But more important than that, even though we were able to map for a much longer period of time, our long-term results were not different when we compared patients who had the procedures done with a hemodynamic support versus those patients who had been ablated without hemodynamic support, suggesting that hemodynamic support is really important for you to keep the patient in good clinical terms. But it does not necessarily help us in terms of preventing VT recurrence in the long term. That's why we've been working on a completely different approach, which is to ablate VT paradoxically in normal sinus rhythm. If we could do that, we would make the VT procedure shorter and much safer by avoiding the compensation of multiple VTs inductions. And we would perhaps be able to discharge VT patients, which frequently stay in the intensive care unit several days after the procedure is performed. We might be, depending on what we do during the case, we might be able to send these patients home the same day, basically like what we are doing with our AFib ablations. One of the important things that is being added to our options is the use of pre-procedure imaging. And I'm going to show you some examples so we can talk about this later. What we know is that if all the different electrograms that we use to classify a potential area, an important area for VT, are related to the scar, and if we know that these electrograms are recorded from bundles, surviving bundles of myocardium that go through the scar, there is a way now for us to map the wall thickness. And this is what you see here. You have a wall thickness gradient. And if there is a potential channel, which is here protected by dense scar in red and not so dense scar in yellow, this would be areas of potential interest for us during our VT ablation. Most likely, these electrograms will live in some of these channels. Not every single anatomical channel, if I can call it this way, that you see here will have interesting electrograms, but most interesting electrograms will be seen in one of these channels. So if we combine imaging plus mapping, perhaps we can take care of the arrhythmogenic scar with no or minimal induction. This is an important concept. What we know is that depending on the substrate, I might be able to induce many different VTs. But if all VTs in this mathematical model has 14 potential VTs related to this specific substrate, why should I induce 14 VTs if instead I could actually take care of the substrate itself, and by doing so, eliminate all these potential VTs. That's what we're trying to do here at the BI. Since I started here in August last year, into 2020. So basically, we're trying to use registration of pre-acquired images, and along with some mapping strategies that I'll show you in a minute. And we're trying to minimize VT induction, and we do the maps with different pacing strategies. We can do that during normal sinus rhythm and or during RV pacing, which is typically normal. But the goal is to modify the substrate enough to be able to control VT recurrence without induction of VT or using a minimally need for VT induction. Let me just show you an example. This is a patient of mine that I did in Brazil a few years, like a year ago. And this is what I'm trying to show. This map, it's a map in normal sinus rate or during RV pacing. What I can see here with all the scholars, what they represent is that, first of all, I have an area with very abnormal potentials, which we'll call late potentials. This area of late potentials is protected by a line of electrical block, which is because here we have viable tissue, and around here we have a tissue that is dense scar. And it's also clear that in one specific part of this potential channel, I have very slow conduction. So I have everything that I need for VT to occur. To be honest with you, if I show this tracing to an electrophysiologist, he may very well tell us that this is like the VT map and not necessarily the sinus rhythm map. When we do this, and we can define our area of ablation, which does not necessarily mean that we are ablating the whole scar, which is represented in here in everything that is not in purple. As you can see, we were able to ablate in sinus, make this scar non-inducible, even though we didn't have to ablate around the entire area of low voltage, which for us means area of scar. This is a different example with basically the same kind of approach. This is again a patient that we are mapping during RV pacing. We found these very late potentials, which you saw before in my initial map. By using these potentials, we can create a map that once again shows us the possibility of a very clear channel with late potentials protected by a line of block. So if we can ablate here, and that's what you see during the propagation map, the wavefront stops here, goes around and comes in this direction. If we ablate this channel, we are going to homogenize the ventricular activation. And by doing so, we might be able to control VT without any VT induction. So we know that's possible. There are several limitations. We're not going to discuss those limitations here, of course, but we can also add to this sinus map strategy imaging. And it's just interesting. This is the first case that I did here, which is an epicardial case. It's interesting because in 2003, when I first came to Mass General, my very first Vt ablation at Mass General was also an epicardial case, which is something that I like a lot. As you can see here, we were able to, this patient came with VT, and you already know that we have areas with dense scar with potential anatomical channels there. And this image was very suggestive that this was actually an epicardial circuit. We did the map for this patient, and as you can see here, we have this is the VT propagating and in what we used to call figure of 8. But what's interesting in this map, so you can understand what we are talking about 3D dimensions before, is that as you can see here, the ventricular activation starts here, goes around up to this point, and then it disappears for a long time. You know, we measure life in milliseconds. So the time between here and here for us, it's a very long time. As you can see here, each color represents 12.5% of the tachycardia cycle length, and it stops in yellow, and it shows up again in dark blue, meaning that at least 30% or 25% of the VT circuit was intramural, was not necessarily epicardial. But we had a portion of the circuit that was epicardial. And we were able to identify areas of interest for ablation during sinus, which is this map here, which you see the red dot there. And the area of interest during VT was exactly at the same point, proving again that you can do a lot in sinus depending on the substrate, and you can have a map in sinus that will help you, that will guide your ablation strategy to stop this ventricular tachycardia even without induction. And that's what we did. This patient was near incessant. We put a lesion there and immediately able to stop the tachycardia during our initial ablation. This is a case that I did a few weeks ago here at the BI. And look, this is the patient with hypertrophic cardiomyopathy. And as you can see here, this is again the scar that was obtained with the pre-procedure CT. And this is it's a difficult substrate because the patient had a mid-wall gradient with the anteroseptal aneurysm. As we were mapping the patient during the case, we didn't try to induce, but during catheter manipulation, the patient went into VT. And I took my catheter and I put it right there in a potential channel. I was not even looking at the VT morphology. I just saw that this was the only channel around this region. I put my catheter there. And sure enough, there was a very interesting electrogram there, which was used to guide our first application, resulting in VT termination very fast. So it's clear that adding image to our map plays a role, at least in some patients. We are trying to explore that to a larger extent, but at least in some patients it's very helpful, and this is just another case. What we are trying to do now is to merge our wall thickness map to our activation map in sinus or during RV pacing. And as you can see here, this is an area of interest represented here by the purple color, which suggests that we have very late potentials here. When we bring the wall thickness over the map, that's exactly where it's supposed to be anatomically. So we can use both pieces of information. We can use the electrograms only, the purple side here, or we can use the anatomical map to guide our ablation strategy. This is the area that we had to ablate, full of these very late potentials there. We then bring our ablation catheter, and once again, the best area for ablation, using criteria that we use out of our ablation catheter, was right exactly where the anatomical isthmus was supposed to be. We did ablate there a lot, and by doing so, we are able to completely change the activation pattern of that region of scar. And as you can see here, able to eliminate these late potentials, which now are gone. There is more about this case, of course, but it's just to show you that now those surviving tracts inside the scar have been completely eliminated, making this patient here non-inducible after the procedure. There is, of course, this whole theoretical discussion if we should use this approach or if we should just inducing VT. And the reason for that is because it's clear that during VT, we have different areas that we cannot identify during sinus rhythm, which is what we call areas which can only be seen during VT if VT is running. So going back to the initial article that I wrote in 1994, I think we have been able to deal with the size of the scar with this new, very important map technologies. We know now that multiple VT morphologies are not even necessary to guide your ablation procedure, and we know how to deal with the epicardial circuits. It's very difficult to overcome the fact that the only way for us to understand many of the functional properties of the scar is during VT. because we don't have enough time to map during VT. So what we're basically trying to do is to establish potential clinical benefit of VT ablation strategy aimed at modifying potential fixed barriers in the VT circuit that can be identified with a detailed map in normal sinus rhythm or RV pacing on top of imaging. Sometimes we use the information coming from the map. Sometimes we use the information that we get from the image recording. Sometimes we combine both information to define our final ablation strategy. This is just very short. I'm sorry, I don't want to prove anything with this. But since I came here in August, we've been evaluating, we've done this kind of approach in 31 patients with a minimal recurrence. The point here is just to show that when you do this, because of course this has no clinical value, right? The outcome here, the follow-up is extremely short, but at least we are not being arrhythmogenic. We are not causing any damage to that specific patient. So our goal now is to expand and try to understand how we can use this kind of ablation maneuvers, ablation strategies to make VT ablation an easier procedure that is applicable to a much larger population that does not require an extremely specialized center for you to refer your patients to. And with that, and thank you for your attention, I would like to finish my presentation and I'll be more than happy to answer any of your questions.
Andre, thanks very much. That was a phenomenal tour de force of a very complicated and complex subject, which is scar-related ventricular tachycardia. Thank you very much for dumbing it down for the likes of me. It is a very complicated thing to understand. It sounds like you've evolved from over the years from mapping in VT to a substrate modified approach. Is there any role still for mapping in VT for patients who have scar-related VT, do you think?
I think, first of all, I'm sorry for this kind of subject for grand rounds, but I think the approach to VT ablation has changed so much now. I forgot to mention that 80% of our VT patients are going home the same day, which completely changes the cardiologist, the clinician's perception about this procedure. That's why I decided to, and I'm sorry if it was too long or too boring. I just was trying to give the cardiologists, especially such a spectacular hospital as MGH, where the field, in my view, is moving to. But to answer your question, I think that yes, in some patients, you map as detailedly, in a great detail, you have your image and you cannot define the substrate properly. In those patients, the only option that you have is to induce, deal with the clinical instability, and try to define your ablation strategy using short periods of induction. But one thing that I'm not doing anymore, Connor, is to go for hemodynamic support so I can map for a much longer period of time. I don't think that approach added much to our ability to control VT in the long term. Of course, I'm all in favor of hemodynamic support if the clinical situation seems to be important enough so patients will benefit from that kind of support, but not for us to be able to map and ablate for a longer period of time.
I think you illustrated that very well with your slide on the left ventricular support device, the Impella, and the changes in cerebral blood flow and measured during sustained ventricular tachycardia. There have been a number of questions regarding the imaging, the pre-procedural imaging. Could you expand on that a small bit more, how it's done and what exactly the workflow is for that?
Well, we have a collaboration with the Lyric Institute at University of Bordeaux our EP friends, they know these people there well. They have a software, they call it Music. Basically, the acquisition, it's a very similar acquisition of CT, the same way you would acquire a regular CT with the slices that have to be as thin as possible. And we send the images to Bordeaux. They process this image and then send it back to us in 24 hours, 36 hours. Once we have the images there are different mapping systems, and one of them allows us to register the image in a very nice way. It's not the same for all mapping systems, but specifically for one that everybody likes and uses, which is Cardio. The image registration is really easy. We use intracardiac echo to obtain this nice registration. And then in Bordeaux and in Spain, they're actually using image only to guide the entire ablation procedure. They're not even mapping anymore. They just register, they show the potential channels, and they try to target and ablate all those potential channels. We are not there yet. I don't think this is, potentially it's the way we're gonna ablate in the future, depending on the energy source that we have. What we are trying to understand here with this approach is, if I can add map to my scar registration, and instead of spending a lot of time mapping the entire ventricle, we spend more time in an area that is potentially interesting. And I have to tell you that I've been very impressed by the ability to properly register images over our ablation, our mapping system. And it's been very helpful to help us delineate the final lesion set. So I'm not sure if I answer the question properly, but it's a software. And what they do, they measure wall thickness and color code the wall thickness, meaning that dark red, it's a very thin, and then yellow is not so thin. And then you can see areas of what we call in EP protected isthmus, which are areas where all those viable tracts of myocardio will live in the middle of the scar. So I have a dense scar here, and of course, we're going to call dense scar based on the wall thickness. The thinner the wall is, the more scar it should represent. And if you have a potential channel of not so scar with an all scar between these two areas, this is the channel where most of those interesting electrograms are supposed to lead.
That's great. Just to follow up on that, there's a question from Jag Singh, who sends on his best wishes, but asks, given the pre-procedural imaging that you're acquiring, is there a role for radio ablation, for radiation-guided therapy ablation for patients rather than an invasive approach?
Thank you, Jack. Absolutely. So one of the things that we are trying to understand, and that's why we're mapping, because we would like to know better if we can, instead of ablate the entire scar where all the channels are going to be present, if we can define based on the mapping, the detailed mapping that we can superimpose the scar, if you're going to be able to identify some specific channel characteristics which are going to be helpful for us to guide our radiotherapy approach. What we are doing now, it's actually interesting, because if the patient has a recurrence after this, and the other day I did a case, patient had two metallic valves, the mitral and aortic valve. So I had to cross from the RA to the LV, which is a risky approach. But since I was able to bring the scar and map over the scar, if this patient has a recurrence, he's been doing great for the last 4 weeks, what we are going to do is to use all this information to guide our radiotherapy. So I think this is the final answer, and it's going to be very helpful in some patients who have a contraindication for catheter ablation. Again, radiotherapy, it seems to be very promising, but you got to use specific subgroup of patients. You don't want to use radiotherapy for a patient who had a VT and he's like 52 years old and has a post-MI VT, right? So we're going to use this kind of approach for selected group of patients. But I believe that the more and more we understand the electrical properties of these specific channels, we're going to be able to use this kind of image information to guide our radiotherapy approach. Thank you for the question, Jagan.
Another question that's come through, just looking into your crystal ball, do you think that the fidelity of this non-invasive imaging is ever going to be as good as the information that you get by actually placing a catheter in the heart and analyzing the electrograms?
I don't think so, but that's what the people in Europe believe, because actually there are basically two groups working on this kind of image acquisition. One is a group from Barcelona, mainly working on MRI, and there is another group in Bordeaux using more CT for the post-MI patients and MRI for the non-ischemic signs. They are already running trials in Europe, during which the electrophysiologist is actually blinded to the electrograms, and they're basically using image fusion to guide the entire ablation procedure. And we don't have results yet, but talking to them, they seem to be very enthusiastic about the initial results. I'd rather map, because I'm not confident enough at this point to use image only to guide my ablation. But I have to tell you that I've been very impressed by the ability of anticipating the interesting electroanatomical map with the scar. So certainly now I don't waste time mapping areas that are completely normal based on the wall thickness, which in the worst case scenario makes your procedure much easier, much faster. And again, you don't need to induce. That's the beauty of it. You can. I like to use the map because I want to make sure that the ablations that were placed, guided by the anatomical map, the CT, or by the EP map, the lesion set that was placed there was good enough for me to change the local activation. So in my mind, I will be mapping and remapping all the time. But again, using images, it's very helpful.
There's a follow-up question from Jag, if you don't mind. We had Shiv Kumar present to us at Grand Rounds the year before last, and Jag's question is, what do you think the role of stellate ganglion ablation or sympathectomy is for these patients? For whom do you offer it, and is it a first-line strategy, second line, or third?
I think it's huge. The role is huge. My problem is how to select patients for that kind of intervention. Again, it's a simple intervention, relatively simple intervention. What we typically do is that when we have patients coming to the hospital because of a VT storm, and we inject in the stellate ganglion, and they have a good response, those are the patients that we typically send for surgical sympathectomy. And I keep asking Shiv, give me a criteria to better select patients who are going to benefit from this approach. And I'm not sure if we have an answer yet. But for me, I mean, I've seen patients who are here in incessant VT, and VT storm, you inject to block the ganglia, and they immediately go into sinus and remain in sinus for as long as the anesthetic is blocking the sympathetic ganglia. It's really impressive. And then they are back in VT, and you inject again, and you get exactly the same results. So those are the patients that we tend to bring to the OR for a more definitive surgical sympathectomy.
This is very helpful. A question from one of our colleagues who has an interest in healthcare economics. Question is, have you done any any analysis on the cost implications of your approach that you've been utilizing at Beth Israel Deaconess Medical Center, in terms of decreased length of stay? Obviously would probably have an impact, but also avoiding the use of invasive left ventricular assist devices and so on?
No, because we don't have enough patients for that. But I can tell you that we're doing so for AFib patients. And we basically save, in terms of direct costs, around $1,800 when we send AFib patients home the same day. not to mention the indirect cost, which is making a bed available for something else. It's interesting that some hospitals are not even ready to answer that question. But in general, I think that if you can minimize hospital stay, as long as you don't compromise the patient's clinical condition resulting in early rehospitalization, I think it can only be good. If we take a FIB as our reference, it's going to be between 1,500 and 2,000 per case. Of course, the economic impact of a Vt ablation, since we don't have a large population of these patients, right? It's hard to get a center that is going to be doing more than 200 of these cases per year. In a FIB is the opposite. You're doing 500, 600 per year. So the impact there, it's a lot more important.
Great. Well, Andre, again, thank you most sincerely for your time, for educating us as always. It was a phenomenal presentation. I think we learned a lot, and it was an absolute pleasure to see you, even virtually. We look forward to seeing you in person again soon.
Thank you very much. Again, it's a great honor for me. I was telling Tony before, this is my 4th time in Boston. I first came as a student and as a research at MGH. Then where I had the pleasure to meet everybody, Patrick, Connor, everybody there, and then as an attending, and now this is my 4th time here. I have a connection with the city, and it's a really great honor for me to have the opportunity to share the kind of work that I'm doing in VT with you guys. Thank you very much for the opportunity, sincerely.
That was great. Thanks so much, Andre. Really appreciate it.
Thanks, Andre. Take care.